Hello everyone, welcome back to this short tutorial from Pathology Made Simple at ilovepathology.com. In this session, I'm sure looking at the illustrations, you might have guessed it. Yes, let's learn about retinoblastoma. So in the next 10 to 15 minutes, we will look into the definition, epidemiology, types, pathogenesis, morphology, clinical features, treatment and prognosis of retinoblastoma. Now, what is retinoblastoma? This is a malignant neoplasm which is derived from the developing retina. When I say developing retina, it's most probably from the progenitors of the cones. I'm sure you know that rods and cones are the most important components of retina, right? So, retinoblastoma is a malignant neoplasm which is derived most probably from the cone progenitors. And this is the most common primary intraocular malignancy of children. It accounts for around approximately 3% of cancers occurring in young children. And remember, 80 to 95% of cases are diagnosed before the age 3 and 5 years, respectively. They are broadly categorized into familial and sporadic types. Familial accounts for around 40% of the cases, whereas sporadic accounts for around 60% of cases. This percentage varies, as some literature says sporadic can be as high as 90% of cases. Familial is transmitted as autosomal dominant. In these cases, often both eyes are involved, whereas sporadic cases virtually always in one eye or single eye. Familial cases are at increased risk of developing osteosarcoma and other soft tissue sarcomas, whereas no such risk in sporadic cases of retinoblastoma. So, to understand retinoblastoma, let us see what is the underlying gene involved. And the gene involved is retinoblastoma gene, which is actually the first discovered tumor suppressor gene, which is located on the long arm of chromosome number 13. And retinoblastoma develops if there is a inactivation of this particular gene. Now, I'm not going to discuss in detail about the functions of retinoblastoma gene because I have already covered this in my earlier session on neoplasia. You can just go through the playlist of neoplasia and can access this video where I have talked in detail about the functions of retinoblastoma gene and the retinoblastoma protein. For the pathogenesis of retinoblastoma, I said inactivation, right? Now, how is this gene inactivated is the question. So, it can be inactivated either by germline mutation or somatic loss of function mutations of the retinoblastoma gene. Another important thing in understanding the pathogenesis of retinoblastoma is to understand this very famous Knutson's two-hit hypothesis, which states two mutations or two hits involving both the alleles of retinoblastoma are required to produce retinoblastoma. Well, let us understand this by the illustration now. We know that retinoblastomas are categorized into familial and sporadic retinoblastoma, right? So at birth, if you look at the genetic component, particularly on the long arm of chromosome number 3, where retinoblastoma gene is located, at birth, in cases of familial retinoblastoma, there is already a first hit. That means there is an inherited mutation of the retinoblastoma gene. So that is the first hit in familial retinoblastoma at birth itself. Whereas it is not so in the cases of sporadic retinoblastoma cases. And all this requires is another hit, right? So the second hit, which is usually an acquired mutation, and if there is a second hit, both the alleles are damaged. Both alleles of the retinoblastoma gene are defective, right? And that leads to the occurrence of malignant neoplasm, that is retinoblastoma. Whereas in cases of sporadic retinoblastoma, you need to have both these hits as per Knutson's two-hit hypothesis, right? So there is first hit, which is usually an acquired mutation again, and the second will also be an acquired mutation at some point of time, leading on to the tumor. The difference between familial and sporadic is familial one, at birth itself, there is already an inherited mutation. I hope you have got this concept clear, right? Now, coming to the subtypes of retinoblastoma, Clinically, they can be unilateral, bilateral, or even trilateral retinoblastoma. Unilateral, usually it could be either due to heritable or sporadic, heritable or sporadic. Bilateral, most often hereditary causes, whereas trilateral is heritable associated with another primary intracranial tumor, and that is pineoblastoma. And it is said that these trilateral retinoblastomas have the worst prognosis. Now, having understood the pathogenesis of retinoblastoma, now let us see the morphological features of retinoblastoma. They are based on the tumor growth, they are categorized into endophytic and exophytic forms. The endophytic is, okay, look at this. This is the section of the eyeball. The endophytic retinoblastoma, the tumor remains attached to the retina. So this is the retinal layer. The tumor is attached to the retina, and then this tumor invades into the vitreous humor. You can find these tumor, deposits within the vitreous humor, right? So that is endophytic. Whereas exophytic is when the tumor arises from the outer layers of the retina, right? So once the tumor arises in the outer layers of retina, and as it grows, there is always a probability or chance of retinal detachment, right? So retinal detachment is most often seen in exophytic kinds of retinoblastoma. And remember, there is always a possibility that most retinoblastomas can be a combination of both endophytic and exophytic forms. Histopathologically, at low magnification itself, you can easily identify retinoblastomas because it looks like as if you're looking at a basophilic mass with pink and purple foci. You can see that this is the layers of the eye, that's the retina, and this is the tumor. You can make out that the darkly stained areas and the lighter stained areas. These lighter stained areas are basically necrotic areas, and the viable areas are the blue areas, blue colored areas, because they hardly have cytoplasm because they have intensely basophilic nuclei along with very scanty cytoplasm. And these viable cells are usually around the blood vessels. Okay, because you get, I mean, these tumor cells gets nutrition from these blood vessels, and that's the reason why the viability of these cells are more often seen around the blood vessels, and that's why they form characteristic sleeves and cuffs around these blood vessels, are also referred to as perivascular cuff of tumor cells. Look at this; these are all the necrotic foci, the lightly stained areas. When you examine the tumor at high power, all you see is intensely basophilic nuclei. Look at this. All these are intensely basophilic nuclei, very closely, placed to one another, which means the cytoplasm is absolutely minimal or scanty cytoplasm. You can also see these special structures called rosettes because the tumor cells are arranged in the form of a flower. There are two kinds of rosettes which you need to remember in retinoblastomas. The most common ones are the Flexner Wintersteiner rosettes. Okay, based on these two individuals. Remember, two men and you have lumen. Okay, so these rosettes have a central lumen, whereas another kind of rosette is a Homorite rosette. Homorite is a single person. That's why there is no hyphen there. Okay, so Homer Wright rosettes, which are named after James Homer Wright, indicates neuroblastic differentiation. Okay, you don't find a lumen here. This pink structure is a neuropil. So this indicates neuroblastic differentiation. But then the most common kind of rosettes which you see in retinoblastomas are these rosettes, Flexner Wintersteiner rosettes. And they actually represent an early attempt at retinal differentiation. As I told you, Lumen, Flexner and Wintersteiner and Lumen. So this is how you remember Flexner, Wintersteiner rosettes, which has a central lumen. And because there are large areas of necrosis you can expect them to undergo dystrophic calcification as well. Now, 15 to 20% of retinoblastoma cases, they harbor a very well differentiated foci which actually, tells you that there is a photoreceptor differentiation. They are seen as aggregates of neoplastic photoreceptors. They are not normal, they are tumorous photoreceptors and they are called as fluorids. These are the fluorids because the term fluorid basically denotes a bouquet-like arrangement of cytologically benign looking cells. They don't look too malignant. They don't have lots of mitosis, okay, and all those things. And these neoplastic photoreceptor inner segments are evident as bulbous eosinophilic processes. Can you see that? So these are bulbous eosinophilic processes which actually form the flowers of these bouquet. Okay, so that's why they are called as fluorids. Now, how do these patients manifest? As I told you, they often present at third to fifth years of life. The most common, mode of presentation is strabismus and leukocoria. Leukocoria meaning white pupil. They can also present with uveitis, endophthalmitis, or even panophthalmitis. And very rarely, advanced cases may present with proptosis or even distant metastasis. How do you treat these retinoblastomas? Most often treated by systemic chemotherapy, and chemotherapy is always associated involved with radiation to the involved orbit and regional lymph nodes as well. Okay, but when the retinoblastoma is already metastatic or if it is metastasized to distant sites, then these are the cases which are best treated with bone marrow transplantation. Now, coming to the prognosis, once you treat these retinoblastomas with chemo and radiotherapy, the survival rate is very, very excellent, reaching up to 98%. And remember, this is what you see in developed countries. Okay, because in developing countries, patients usually go at a very later stages and in advanced cases, and that's where we call what are the poor prognostic indicators of retinoblastoma. If it has already metastasized, if the tumor is undifferentiated type, or if there is very massive choroidal or optic nerve invasion. If you find any of these, the patients do not really fare well. So that's about retinoblastoma, guys. So we have learned about the epidemiology, the types, the pathogenesis, morphological features, particularly the gross and microscopic features, clinical features, a bit about treatment and prognosis of retinoblastoma. Thank you for watching. If you like the video, hit the like button. Do comment. Ask me any topic if you want me to cover. I'll try to cover as far as possible. And if you consider that this video has helped you, do consider subscribing the channel and also don't forget to share. Thank you.